Hello, good evening. In the previous lecture, I discussed iron metabolism and how iron metabolism is related with hemochromatosis. In the second lecture, I will discuss the genetics, pathophysiology, clinical features, diagnosis, and management of hemochromatosis. Hemochromatosis is an autosomal recessive disorder. That means the parents of the affected person will be heterozygote or carrier. And this is also important, as you know, this is an autosomal recessive disorder. So not only to treat the patient, you also have to screen the family members and especially the parents and other siblings of the particular patient we are discussing. Okay, so this is important. And another thing is you have to remember the gene, the mutated gene in hemochromatosis, HFE gene, and also the mutation as well, like C282Y mutation and H63D mutation. So far I can remember. You have to remember the two mutation as well. Okay, and what happened in hemochromatosis because of these mutations? Because of these mutations, as I discussed in the previous lecture, the regulation of iron absorption in GI tract in enterocyte is interrupted, and enterocyte absorb inappropriately excessive amount of iron, and this excessive amount of iron deposits in certain organs and producing the signs, symptoms and complications of hemochromatosis. So from the first lecture, can you remember the organs where iron is preferably deposited? If I can recall, number one is liver. So in hemochromatosis, you are going to expect abnormal liver function test, hepatic pattern of abnormal liver function test, that means mostly elevated transaminase, cirrhosis, and there is a great risk of hepatocellular carcinoma as well, 40-fold increased risk of hepatocellular carcinoma in hemochromatosis. Okay, and this excess iron overload can be diagnosed by MRI scan of the liver, and also can be diagnosed by liver biopsy. Okay, and second important site of iron deposition is heart, and in hemochromatosis, arrhythmia, heart failure is not uncommon, and this is a very important complication because when we are going to discuss the management of hemochromatosis, we will see that how it is related if the patient have coexisting heart disease, heart failure as well. Okay, so second is heart. Number three is pancreas, especially the endocrine pancreas or islets of Langerhans, which will be affected with low insulin secretion, and hemochromatosis is a non-secondary cause of diabetes mellitus, especially insulin dependent diabetes mellitus. You have to remember this because if someone asks about the management of diabetes in hemochromatosis, whether you are going to give the patient oral anti-diabetic medicine or whether you will treat him by insulin from the beginning. The answer is insulin, obviously. Okay. So number four is skin. Hemochromatosis is a known cause of hyperpigmentation, and because of this diabetes and hyperpigmentation, hemochromatosis is also known as bronze diabetes. This all we discussed in the first lecture, in the previous lecture. So number five is pituitary, especially the gonadotroph cell of the anterior pituitary, and hemochromatosis, Kallmann syndrome, and hypopituitarism due to any other cause are the commonest cause of hypogonadotropic hypogonadism. That means low FSH and LS with hypogonadism. Okay. In exam question, you may only find abnormal liver function test, and in somewhere in the investigation data you may find low FSH LS. Low FSH and LS may be the only clue that the examiner expecting from you to answer hemochromatosis as the cause of abnormal liver function test. And in a person with diabetes mellitus and abnormal liver function test, it is of course sensible to think non-alcoholic steatohepatitis or NASH first, but you also have to remember that diabetes plus abnormal liver function test can also be a manifestation of hemochromatosis. Okay. The number 6 complication in hemochromatosis is arthritis, especially early osteoarthritis, and hemochromatosis is also a known cause of cartilage calcification or chondrocalcinosis, which may predispose to pseudogout. Alright, so these are the signs, symptom or clinical feature and complications of hemochromatosis. And the screening test for hemochromatosis is transferrin saturation and serum ferritin. You have to remember the cutoff value of serum ferritin and transferrin saturation. And so far I can remember is transferrin saturation is 45% and ferritin is probably 500 microgram or something. There is difference in male and female, which you also have to remember. And of course you have to investigate other complications of hemochromatosis like diabetes, ECG and echocardiography to check the heart, FSSLS for hypogonadism. This also you have to check. And now how we are going to confirm hemochromatosis? Of course, though the screening test of choice is ferritin and transferrin saturation, but the confirmatory test for hemochromatosis is HFE gene mutation C282Y and H63G. This is a routine practice to diagnose hemochromatosis, HFE gene mutation. And now the management of choice for hemochromatosis is venesection or bloodletting. Okay, if the patient is venesected regularly, definitely iron will be lost, and you have to keep his or her ferritin level below 500. Okay, below 50. Sorry, below 50. The target is below 50 to avoid complications from iron overload. So in person with heart failure, coexisting heart failure, it may be difficult to perform venesection because anemia may worsen symptoms of heart failure. So in such case, iron chelating therapy like desfloxamine injection is the treatment choice. All right. So this is all about today. I'll discuss copper metabolism and Wilson disease in my third lecture. Thank you for watching this video. Thank you.